Global pediatric innovation has yielded remarkable diagnostic and therapeutic advances over the last decade. Yet every 15 seconds, a child in a remote or destabilized region is denied life-saving care. The medicine exists, but the patients die waiting for it. The decisive failure here is organizational. The medical challenge is solvable, but the children perish in a gap between diagnosis and authorized transfer, a breakdown known as the discontinuity of care. When a clinician identifies an emergency transfer need, the pathway relies on a fragile, human-mediated chain. Each handoff is a potential failure point. Routine personnel turnover constantly severs trusted channels, while consular officers, lacking rapid clinical expertise, reject unverified field data out of institutional doubt. Because of these continuous manual verifications and broken communication links, authorization timelines stretch from hours into weeks, trapping critical patients in a bureaucratic void. The delay between diagnosis and transfer is a systems engineering problem masquerading as a diplomatic one. Solving this governance gap requires abandoning individual communication channels. We must replace them with verifiable architecture. The SOS Safe Passage Beacon system establishes a continuously connected community, an unbroken infrastructure of trust linking remote clinics directly to centralized decision-makers. This specific architectural blueprint relies on role-anchored communication rather than individual identity, and it operates across 3 tightly integrated layers. First, Layer 1 is a physical hardware trigger, engineered specifically for survival and immediate deployment in the most extreme field conditions. Next, Layer 2 acts as a secure relay, establishing absolute cryptographic trust and role-based routing for all incoming field data. Layer 3 is the destination, a cloud-based coordination hub where final case resolution and placement occur. Establishing rigorous data provenance across these 3 layers addresses the procedural causes of institutional skepticism, clearing the path for faster authorization. The system activates in harsh realities. Clinicians in destabilized zones or severe weather cannot navigate complex authentication protocols while managing acute trauma. To meet this reality, the SOS Safe Passage Beacon is built as a single-purpose, tamper-proof physical device that requires minimal training to operate. Upon activation, the device immediately captures a precise payload of information: acute clinical data, raw imaging files, and verified GPS coordinates. Getting data out of a remote zone requires robust infrastructure. The beacon utilizes low Earth orbit satellite networks, transmitting the packet instantly. As data hits the network, the Telemetry API appends 3 specific pieces of metadata: geolocation, latency, and uptime. That latency and uptime metadata mathematically verify the physical origin of the beacon signal, proving exactly where and when the transmission occurred. This specific combination of location tracking and transmission telemetry establishes what is known as hardware-level provenance. Securing hardware-level provenance creates a baseline of absolute trust before a human operator even touches a keyboard. The device itself verifies the event. Once data leaves the satellite, it enters Layer 2. Transmission flows through open-source, end-to-end encrypted channels, using matrix protocols and a signal field interface. Instead of routing to individuals, the system uses role-based accounts. A packet is sent directly to the position of Embassy Liaison Kenya. During handoffs, an automated pass-the-torch protocol transfers credentials instantly to the new officer, keeping the stream unbroken. The pass-the-torch protocol solves the turnover problem, but the medical data still faces immediate consular skepticism upon arrival. To prove authenticity, the software layer deploys the Integrity Truth Algorithm, or ITA-VQ Veracity Quotient protocols. ITA-VQ applies cryptographic hashes to all clinical imagery and documentation at the exact fraction of a second they are captured by the beacon. This mathematical verification proves to consular officials and visa authorities that the files have not been altered, edited, or forged in transit. Providing instant cryptographic proof eliminates the need for manual, time-consuming background checks on field documentation. The data arrives pre-verified. Layer 2 replaces individual dependent trust with a persistent, mathematically verifiable infrastructure that remains intact even as personnel rotate. The SOS system intentionally avoids building a redundant destination platform. Instead, it serves as the necessary trigger for an existing, highly capable environment. Layer 3 is the Children's Resource Exchange, or CRE. The verified packet ingests directly into this hub. Inventive artificial intelligence models instantly process the payload, rendering complex field data legible across multiple languages and standardizing the terminology. Using these verified diagnostics, the AI rapidly directs an actionable mission plan, identifying the exact level of care required. From there, the network automates the critical coordination steps, activating emergency funding, initiating humanitarian visa workflows, and scheduling medical transport. All of this occurs within a single auditable environment, allowing receiving facilities to prepare and giving parents or guardians continuous, secure updates on the process. The hardware trigger and API bridge link field clinics directly to billions of dollars in existing humanitarian infrastructure that governance gaps previously made unreachable. Proving this architecture requires rigorous field testing. The initial 6 to 12-month pilot will manufacture and deploy 50 pre-authenticated beacon devices and officially enroll 15 to 25 verified decision-makers into the role-based system. Deployment targets 3 specific geographies with verified low Earth orbit healthcare networks: the Philippines, Kenya, and Appalachian, Virginia. The primary metric for success in these live cases is time. The system aims to reduce the escalation to transfer authorization timeline from weeks down to under 48 hours. In direct alignment with the MIT Hood Hub's mandate to dismantle barriers to innovation, this project ensures the resulting technology will not be siloed. Upon completion of the pilot, both the Pass the Torch Role Transfer Protocol and the ITA-VQ Authentication Bridge will be open-sourced and contributed directly to the Hub's Innovation Commons. Funding this foundational, continuously connected infrastructure creates the reliable delivery mechanism required to accelerate the translation and adoption of all future life-saving pediatric technologies.